Hello, everybody. The topic under discussion today is fascia lata part 2, which comprises of modifications of the fascia lata and their clinical relevance. So, at the end of this session, the participant should be able to describe the iliotibial tract regarding its attachment, extent, and functions. Describe the iliotibial band syndrome regarding its sign, symptom, causes, and treatment. Describe the Cribriform fascia and Saphenous opening. Describe the intermuscular septa, that is lateral, medial, and posterior, and coverings given by the fascia lata. Their extent, attachment, and functions. Describe the fascial compartments, that is anterior, medial, and posterior, their formation and functions. And finally, should be able to describe the thigh compression syndrome regarding its sign, symptom, causes, and treatment. Iliotibial tract is a longitudinal lateral thickening of the fascia lata. It is about 5 cm wide anteroposteriorly and is more wide in its upper part. As regards the attachments, it splits in its upper part into two laminae at the level of femoral tubercle. The superficial lamina gets attached to the iliac tubercle and the adjacent iliac crest, whereas the deep lamina, which is present only in its anterior part, gets attached to the capsule of the hip joint. Between these two laminae, iliotibial tract receives gluteus maximus insertion posteriorly and tensor fascia lata insertion anteriorly. The iliotibial tract passes downwards and gets attached at a smooth area at anterolateral surface of lateral condyle of tibia. As regard the main functions, iliotibial tract stabilizes knee during extension and partial flexion of the knee. Hence, it is used constantly during walking and running. It also provides main support to the knee against gravity when knee is slightly flexed. With its associated muscle, the tract extends, abducts, and laterally rotates the hip. It also gets attached to the lateral intermuscular septum, or lateral intermuscular septum is attached into it. Hence, these two structures, that is lateral intermuscular septum and iliotibial tract, keep the muscles of the anterior and posterior compartments close to the femur during movements. It also provides muscular sheath to the tensor fascia lati. Iliotibial tract or iliotibial band syndrome is the inflammation of the tract as it crosses lateral femoral epicondyle. This syndrome causes severe pain in the region. Let us have some anatomical considerations before we go on to the syndrome. Iliotibial tract lies in front of the lateral epicondyle when knee is extended. It makes contact with the lateral epicondyle when knee is flexed to 30 degree. And the tract lies posterior to the lateral epicondyle beyond 30-degree flexion. There is a bursa interposed between the tract and the lateral epicondyle, which facilitate the sliding of tendon over the epicondyle. The causes of this syndrome are: number one, prolonged effort in the same range, as seen in runners and cyclists; increased physical activity along the slopes and stairs. Some anatomical factors also are to cause this syndrome. These are flat feet, genu varum, increased internal rotation of tibia, excessive rigidity of iliotibial band, and contracture of the fascia lata. The patient complains that activity triggers the pain, which gradually increases with more physical activity and decreases with the rest. The treatment of this syndrome is three-tier. In the first tier, which is conservative treatment, the patient is asked to decrease the activity, is prescribed anti-inflammatory drugs, and along with physiotherapy. Second tier is in which we infiltrate some steroids in the affected area, which relieves these symptoms in some of the cases. If nothing happens because of conservative treatment and the steroid infiltration, then third tier is the surgery, in which partial tenotomy, that is resection of the inflamed part, is performed, and the recovery is almost complete in about 2 months. Now we come on to the description of saphenous opening and the cribriform fascia. The saphenous opening is an oval gap in the fascia lata located below the medial part of the inguinal ligament and serves as an entry point for lymph vessels and great saphenous vein and its tributaries. It is approximately 3.75 centimeter into 2.5 centimeter in size and is located approximately 4 centimeter infralateral to the pubic tubercle. Its medial margin is ill-defined and smooth and is formed by deep lamina of the fascia lata. On the other hand, its inferolateral margin, which is also named as falciform margin, is a well-defined crescentic shape thickening in the superficial lamina of the fascia lata. It is covered by fibrofatty tissue, which is named as cribriform fascia. It appears sieve-like because it is pierced by, number one, great saphenous vein and its tributaries which open into femoral vein. Number two, lymphatics from superficial inguinal lymph nodes to the deep inguinal lymph nodes. Septa and fascial coverings provided by fascia lata. There are three septas provided by fascia lata: lateral intermuscular septum, medial, and posterior. First, the lateral intermuscular septum. It is the stronger of the three and extends from greater tuberosity to lateral condyle of the femur. It is attached onto iliotibial tract laterally and lateral lip of the linea aspera medially. It separates vastus lateralis muscle in the anterior compartment from the short head of the biceps in the posterior compartment. It also gives partial origin to these muscles. Second is the medial intermuscular septum, which is relatively thinner and extends from fascia lata to medial lip of the linea aspera. It separates vastus medialis in the anterior compartment from the adductor muscles in the medial compartment. Third is the posterior intermuscular septum, which is poorly defined. It extends from fascia lata to medial lip of the linea aspera and separates medial and posterior compartment contents from each other. In addition, fascia lata provides number one, numerous small septa which separate the individual muscle. Number two, it also provides fascial sheath to individual muscle. Number three, it also encloses neurovascular bundle in the adductor canal. Fascial compartments of the thigh. A fascial compartment is a section within the body which contains muscles and neurovascular bundles and is surrounded by deep fascia. Walls of the fascial compartments of the thigh are formed by fascia lata and three intermuscular septa, that is lateral, medial, and posterior. There are three compartments of the thigh. The anterior, which is also named as extensor compartment, contains sartorius quadriceps and articularis genu muscles. Medial or adductor compartment, which contains pectineus, external obturator, gracilis, and adductor muscles. And the third one, the posterior, which is also named as flexor compartment, contains hamstring portion of the adductor magnus, biceps femoris, semitendinosus, and semimembranosus muscles. As regard the functions of fascial compartments, they provide space for muscles and neurovascular bundle and also provide plane for wide exposure of the femur during operations. Thigh compression syndrome is a devastating lower limb condition in which compartment pressure rises to a level that decreases perfusion to the thigh tissue. This increased pressure may lead to irreversible muscle and neurovascular damage. Patient complains pain in the muscles, swelling or bulging of the muscles, and he or she also complains numbness, weakness, and tightness in the thigh. This condition may be caused by blunt injury to the thigh or too tight a bandage or plaster cast as applied in the emergency. The treatment of this syndrome is to remove the cause, obviously, and also anterolateral fasciotomy of the thigh, in which the fascia lata at the anterolateral aspect of the thigh is incised so that the compartmental pressure, increased compartmental pressure is released. Comments and suggestions will be welcomed. Thank you for listening and watching.